Hit the subscribe button or visit us at auau.auanet.org.
Good evening, and welcome to AUA's Metastatic Hormone Sensitive Prostate Cancer Expert Guidance for Urologists. We thank you for joining us for this discussion. Before we get started, we'd like to go over a few items so you know how to participate in today's event. The AUA is accredited by the ACCME and designates this Internet Live activity for a maximum of 1 AMA PRA Category 1 credits. Evaluations are very important to us. Course evaluations and CME credit will be administered electronically on AUA University immediately following the activity. As the AUA continues to develop virtual education that meets your needs, we welcome your feedback regarding both the content and format of this activity. Upon completion of the course evaluations, you will have the opportunity to claim CME credits and obtain a certificate. All persons in a position to control the content of an AUA educational activity are required to disclose any relevant financial relationships with any common commercial interests. Please visit the AUA University to view faculty, education council, and COI review work group disclosures. Coding advice given during this presentation are the opinions of the presenters and may not have been vetted through the AUA for accuracy. Please verify accuracy prior to reporting on medical claims. We hope that you will actively participate as you learn and connect to each other during this course. Due to the size of the audience, all participants will be in listen-only mode without video, but we do encourage you to ask questions at any time through the Q&A pane. Please stay tuned for a keyword that will be provided during the activity. The keyword is used to verify your participation in the activity. You will need this keyword to access the course evaluation, CME credit claim, and certificate. The AUA would like to thank Astellas, Janssen Biotech, Inc., administered by Janssen Scientific Affairs, LLC, and Pfizer, Inc., for providing independent educational grants in support of this activity. Finally, I'd like to extend a special thank you to our course director, Dr. Todd Morgan, for his time, talent, and expertise in developing this program. I will now turn the activity over to Dr. Morgan to begin our knowledge assessment.
Well, thank you so much. Thanks to everybody for joining us tonight. We really have a great group of experts with us. I know it's going to be a very educational hour. Before we begin the live panel, we do have this brief knowledge assessment. I'm sure many of you have done this before. And then at the close of the discussion, we will have a follow-up assessment using the same questions. And so the results help the AUA measure educational effectiveness of this live education activity, and then they aid in the development of future activities. So I'm going to just read them. Please, fill them out as we go. First one, side effects associated with abiraterone include fatigue, confusion, and seizures, hypocalcemia, fatigue, and dyspnea, myelosuppression, diarrhea, and fatigue, hypertension and hypokalemia, or systemic allergic reaction and anaphylaxis. Give you a few seconds. We don't have like the timer, I guess, anymore, or background music. Okay, I'm gonna go to the next one. In a 60-year-old male with a germline BRCA2 mutation and newly diagnosed grade group 5 prostate cancer with 2 vertebral metastases, which of the following treatment options would be concordant with AUA guidelines? Abiraterone and prostate radiotherapy, ADT and apalutamide, olaparib, or ADT and radium-223. I think last time I did this, I told jokes in between, but I'm gonna spare you this time. Okay, I'll keep going. The proportion of men with metastatic prostate cancer who harbor germline mutations in DNA damage repair genes is approximately 2%, 5%, 12%, or 20%. And number 4, a 70-year-old male with newly diagnosed prostate cancer is found to have 6 bone metastases, as well as pelvic adenopathy. In addition to ADT, which of the following would be appropriate to recommend? Darolutamide, sipuleucel T, enzalutamide, or bicalutamide? I'm going to number 5. This is the last one. A 55-year-old male underwent a prostatectomy followed by salvage radiotherapy a year later for what was PT3B Gleason 4+4 prostate cancer, and he now has a PSA of 4.2. In which of the following scenarios would initiation of ADT and abiraterone be appropriate? So pelvic and retroperitoneal lymphadenopathy on a CT abdomen and pelvis, vertebral metastases visible on an Axman PET but not conventional imaging, negative CT and bone scan with a PSA doubling time of 3 months, or PSMA PET with diffuse metastases, including the axial skeleton and liver. Give a little bit more time for everybody to answer those.
Looks like we're close to 50% of you have responded. So those of you who have not yet, please go ahead and submit your responses now, and we will close the poll in just a few moments.
Yeah, please join in if you can.
Give it just a few more moments. We're up to about 75%. Okay, that concludes our knowledge assessment. Thank you for participating, and I will now turn it over to Dr. Morgan.
Great. So let's see. The next slide has the goals, right? That you guys controlling that? Maybe. Yeah. Okay, great. So the activity goal is to increase our understanding of how to translate the recent Advanced Prostate Cancer Guidelines, which were the AUA, ASTRO, and SUO, all in collaboration, and translating these into clinical practice in order to improve the care of their patients, of our patients. Go ahead to the next slide. And we've got these learning objectives outlined here. We're going to work on identifying the active agents and how they work for treatment of metastatic hormone-sensitive prostate cancer. We'll talk about the evidence and outcomes in the treatment of, again, metastatic hormone-sensitive prostate cancer, specifically as they relate to the newly released guideline. We'll review how to improve diagnostic and therapeutic decision-making. And in application, we'll talk about specific cases. We'll analyze breakthrough treatments in management of advanced metastatic hormone-sensitive prostate cancer, and then describe the indications and combinations for treatment with approved agents in the management of mHSPC. So I think that gives me the chance to now introduce our panelists. We're really lucky. We have an amazing set of multidisciplinary panelists. First, I'll introduce Dr. Kelvin Moses. He's Associate Professor of Urology and Fellowship Director for Urologic Oncology. He's Director of the Comprehensive Prostate Cancer Clinic at Vanderbilt. He has tremendous expertise in advanced prostate cancer. He conducts really important research on health disparities. And thank you, Kelvin. We're very fortunate to have you here. Next, I'll introduce Dr. Anna Aparicio. Dr. Aparicio is Associate Professor in the Department of Genital Urinary Medical Oncology at MD Anderson. She's a leader in both translational science and clinical trials, and in my opinion, one of the rare individuals who can bring laboratory findings truly into clinical practice. And so we can't thank enough for joining us here tonight. And then finally, Dr. Ali Berlin. Dr. Berlin is a clinician scientist and radiation oncologist at the Princess Margaret Cancer Center. He's also medical director of the Smart Cancer Center and data science programs at Princess Margaret. He has expertise in molecular and MR imaging, and I would say it's just a well-known fact that the team up in Toronto exemplifies multi-D care. They're a few hours north of us, and we look at them and really try to learn from what they're doing. So thank you, Ali, for joining us. It's great to have all of you here. So let's get going. We're going to start by identifying the active agents and mechanism of action. That's the first segment. This is broken up into 4 separate segments. And I'll start with Kelvin. Can you remind us how GnRH agonist therapy works and contrast that with the GnRH receptor antagonists?
Sure. Hopefully everybody can hear me well. Thanks, Dr. Morgan and everybody. So GnRH agonists are compounds that stimulate the GnRH receptor in the hypothalamus. And this causes release of FSH and LH from the pituitary. And this is part of the hypothalamic pituitary testis axis. And so with it being an agonist, it actually causes an initial flare of testosterone due to release of LH. However, continued stimulation desensitizes the pituitary and thus suppresses testosterone at 95% or greater reduction, which is called castration level. In comparison, GnRH antagonists compete for binding to the receptors and thus block GnRH action within the hypothalamus and in the rest of the body. The difference being that you don't see the flare of testosterone. So this provides fast suppression of testosterone without a surge. The Prostate Cancer Working Group 2 defined castration level of testosterone as less than 50 nanograms per deciliter. And that's pretty much used as a standard. However, there are some experts, including some recent panels earlier this decade in San Antonio and Paris, suggesting that castration level should be defined as less than 20 nanograms per deciliter, because that's what's routinely achieved by surgical orchiectomy. Some of the common short-term and long-term side effects include fatigue, hot flash, weight gain or weight loss, erectile dysfunction, loss of muscle mass, bone depletion, increased risk of cardiovascular or thromboembolic events, and increased risk of either diabetes or metabolic syndrome type appearance. And the vast majority of these are given either intramuscular or subcutaneous in 1, 3, 4, or 6-month formulations.
Awesome, thank you. That was a phenomenal summary. So now, that covers kind of our foundation, but now how about the next generation AR targeted therapies that are available in this space? Maybe Anna, can you walk us through some of those?
Sure. So we have obviously the 2 sort of general types of secondary hormone agents. One is the abiraterone acetate, and this is a drug that inhibits CYP17. CYP17 is an enzyme of the steroid hormone synthesis pathway, and it's expressed in testicular and prostate and adrenal tissues, and it basically results in the synthesis of androgens in these organs. So when you inhibit CYP17 with abiraterone, it results in a reduction in the synthesis of androgens. And that's its mechanism of action. It was first approved in 2011 for the treatment of metastatic castrate-resistant prostate cancer, and later in 2018 for the treatment of metastatic hormone-sensitive prostate cancer. Its most common toxicities are hypertension, hypokalemia, transaminitis, and cardiac toxicity and fatigue. It's important to note that the hypokalemia and hypertension happen because the inhibition of CYP17 also results in an increase in ACTH, which in turn drives an increase in of cortisol precursors with mineralocorticoid activity. So that's the reason to co-administer abiraterone with low-dose prednisone or other glucocorticoids that will block this compensatory increase in ACTH and thus reduce the incidence and severity of hypertension and hypokalemia. The other drugs approved in this space that have a hormonal action are enzalutamide and apalutamide. These are second generation non-steroidal androgen receptor inhibitors. And what they do is that they compete with androgens for the ligand binding domain of the androgen receptor. And this doesn't allow the AR to get into the nucleus and do what it does there, bind to the DNA and unleash this androgen receptor mediated transcription. Enzalutamide was also first FDA approved in 2016 for metastatic castration-resistant prostate cancer like abiraterone. Apalutamide was approved a little later in 2018, and its approval is for non-metastatic castration-resistant prostate cancer, although of course, as one would imagine, based on the mechanism of action, there's no reason why it shouldn't work. They were actually both approved in 2019 for the treatment of metastatic hormone-sensitive prostate cancer. Again, common side effects include hypertension, fatigue, cognitive and memory impairment. And there's been reports of falls and fractures and syncope. It's interesting that they have a slightly different structure, chemical structure, and that apparently justifies two unique toxicities of apalutamide that are rash, which actually can be reasonably severe in about 5% of patients, but can go away with holding the drug and sort of topical treatments. And the other thing that's interesting with apalutamide is that it results in faster metabolism and clearance of thyroid hormone. And so that can cause an increase in TSH and hypothyroidism, although generally it's mild and asymptomatic, and it occurs mostly in patients that had a prior history of hypothyroidism. Both of them are known to cross the blood-brain barrier, and in earlier trials, there was a concern that enzalutamide increased the risk of seizures. Although in larger trials, this was actually, wasn't borne out. Although of course, people that had seizure risks were excluded from the larger trials. So that remains part of the indication. And the only other thing in enzalutamide and apalutamide that I think is worth noting is that they can both decrease the plasma exposure to drugs such as warfarin via the cytochrome P450 enzyme inhibition. So one has to be a little bit careful with drug-drug interactions when using these trials.
Wow, thanks. That was great. So, I mean, it seems that first generation anti-androgens like flutamide, bicalutamide have fallen out of favor. Ali, would you say that that's correct?
Yeah, totally. So actually there was a randomized trial in the late 90s published by the UK group comparing Casodex monotherapy versus castration. And it was shown that patients receiving for metastatic disease had Casodex had worse overall survival versus castration, either surgical or medical. And it was more evident in the M1 disease. I think the popular clique of the use of anti-androgens is because they're better tolerated, because it's known that these first generation agents actually have some partial blockage of the AR pathways and also have some agonist effect, some of them. So obviously the patient's quality of life is better, but in terms of oncologic outcomes is worse. There's a different topic that it's a bit tangential, which is in the M0 biochemical recurrent, where these agents may have a role in very elderly patients with shortened survival, but again, acknowledging a compromise in terms of oncologic outcomes. And now I would say even the tendency when it's M0 recurrence is even withhold any hormonal intervention. So I think the pendulum has shifted away from these drugs and they're not recommended. Probably the residual indication is in some combinations with radiotherapy trials are still being used. And the other one is initially, as Calvin described, for controlling the flare, which we know now by HERO trial can be up to a 50% increase on the testosterone in the span of the first 1-2 weeks after initiation of LHRH agonist. No so much obviously with the antagonist or the new oral agents. But when you're using those agonists, it's recommended to breach initially with anti-androgens to avoid flare in patients that rise in testosterone can boost or let's call brackets inflame your tumor and could cause symptoms or progression in context of cord compression, so on and so forth. So that's kind of the role that they have now in this space.
Yeah, I mean, that's a great point about primary radiotherapy. It seems like a lot of the clinical trials that have been historically, run, and I mean, 20 plus old data uses these drugs, but even for treatment of men with localized prostate cancer undergoing radiotherapy, it's rarely used now, right?
Extremely rare. Even in the salvage setting, there was the G2 and the RTOG trial using bicalutamide for 2 years, even though it's level 1 evidence in a phase 3 trial. It's very rarely used in practice. So I think these are confined now to the management of the flare.
Great. Super. So the last kind of key class of agents we haven't discussed in this section is chemotherapy. So docetaxel obviously has a role in this setting. Maybe Anna, can you remind us how this works and how this is different and how you think about this in patients with metastatic hormone sensitive prostate cancer?
Sure. So docetaxel is, of course, a cytotoxic chemotherapy. And what it does is it binds to the beta tubulin. And so it prevents the depolymerization of the microtubules during mitosis. And basically what happens is cells can't divide and they die. The other thing that it seems to do is that because it sort of prevents this or stabilizes the microtubules, it inhibits cellular trafficking of protein. And one of the proteins that is inhibited, one of these proteins is actually the androgen receptor. It looks like docetaxel can also inhibit the androgen receptor translocation into the nucleus and its expression in vitro. So, the relevance of that in vivo remains to be determined. It was first FDA approved back in 2004 for metastatic castration-resistant prostate cancer. As most people know, the most common toxicities are alopecia, fatigue, anemia, diarrhea, nail bed changes, and peripheral neuropathy. Generally, these are not severe, but it does depend a little bit on the performance status of the patient. And you do see, so clinical trials report febrile neutropenias in anywhere from 8 to 15% of patients.
Awesome. And so this slide that's up right now, those of you who are watching live can see. I imagine all of this is downloadable later for anybody who's listening to this even later. But this is a summary of the active agents and the adverse effects. I would just highlight that the answer to one of the questions is on here, so you can take a look for abiraterone. It's important just to keep in mind that some of them have overlapping mechanisms of action, but the side effects are different as everybody's highlighted. So let's go to the next segment. We'll call up the next slide here. So this is where we get to really start digging into the AUA ASTRO SUO guideline. And I guess I'm a little bit biased here because I was on the guideline committee, but this is a really excellent guideline. It was developed in a multidisciplinary fashion. It included urologists, of course, radiation oncologists, medical oncologists. So there are a lot of issues that need to be teased apart. And so this guideline is the first one that really spans multiple disease settings in advanced prostate cancer. So there previously was a guideline focused on castrate-resistant prostate cancer. And this spans basically from the time of biochemical recurrence following kind of maximal local therapy. So once local therapy options have been all used up, so biochemical recurrence at that point, all the way from mHSPC, including non-metastatic castrate-resistant prostate cancer, including metastatic castrate-resistant prostate cancer. And so to make this guideline, it went through both an intense data review, multiple iterations of virtual and in-person meetings to come up with the guidelines. And these AUA guidelines, as all the AUA guidelines do, they include both the relative strength of the evidence and the specific strength of the recommendations. And those get different categories, and also the clinical practice recommendations. So I just would urge everybody to take a look at those if you haven't had a chance already. I would also just point out that it's a living document and it does get updated over time, so it continues to stay current. So we've spent some time kind of thinking about the first initial evaluation of a patient with metastatic hormone-sensitive prostate cancer. And I'll start with you, Kelvin. In a patient with a new presentation of mHSPC, is a biopsy necessary?
Yes, it is. And there's a couple of reasons for that. Number one, you do need histologic confirmation of the type of disease. And it can give you some other information if there's a small cell component, neuroendocrine, something like that. And in our experience, of course, a medical oncologist is not going to let us move forward until we do have a diagnosis. Secondly, that tissue can be used for genomic sampling, which could have some implications for treatment later down the road. And I believe we're going to be talking about that later. Now, in a patient where they cannot tolerate a biopsy, or if the visible sites are inaccessible, then you can go ahead and treat. It doesn't really make sense to delay someone if their PSA is 500 and they've got skeletal metastases, like that's prostate cancer, and obviously go ahead and treat someone. But certainly in an ideal situation, you would like to have a biopsy confirmation.
Yeah, agreed. So now, in that patient with an initial presentation, what does the initial staging evaluation look like? What scans you're ordering?
Yeah, so if you look at all the clinical trials, what is considered conventional imaging would be a CT or an MRI. And this would include at least the abdomen and pelvis, and then a technetium bone scan. Now, obviously, there are some who have access to more advanced imaging like Axemin or PSMA, and that certainly are more sensitive type tests, but certainly the baseline would be a CT and a bone scan.
Yeah, and we'll get to the next generation imaging a little bit later, because that is potentially going to change a lot of this discussion, and I don't think any of us know in what ways, but we can guess. So, when we talk about this, a patient who's newly diagnosed with metastatic hormone-sensitive prostate cancer, I think the key trials have sought to classify disease extent, and that's kind of been a really fundamental piece of kind of assessing prognosis. But they've done it in different ways. So, Ali, maybe you could cover a little bit on how they've done it and how we should think about disease volume in this setting.
Sure. So, well, I think it's very important to have some clarity in these concepts, because as you mentioned, these were either selection criteria within the trials that demonstrated benefit on certain groups in a subset of patients, or were stratification factors that show differential benefit across different populations within the M1 space. And these has evolved over time. There's more nuanced understanding, and there was data from the Stampede group presented in ESMO a couple of years ago, also showing that maybe some of these definitions may vary in terms of the effect that it's observed. But just to try to keep it simple, so one is the Latitude trial that we're going to discuss probably after, that explore the use of abiraterone, and they define patients with M1 and high risk, which for them was the presence of 2 out of 3 features, being Gleason 8 to 10, 3 or more bone metastases, and or the presence of visceral metastases. Those 2 permutations, or the 3 of them, will categorize a patient as high risk. Then there was the definition of volume using the Uncharted trial, which was a trial that explored the benefit of docetaxel over a backbone of ADT, and they defined low and high volume disease. And the high volume was the definition essentially, which was more based on disease burden, and was again visceral metastases, and that's where the confusion may come with the high risk, because it's the same factor. Instead of 3 bones or more, these were 4 or more, with one of these lesions being outside of the pelvis or the spine. So it's essentially those 2 criteria that make it. So it's 4 or more bone metastases, with the caveat that one has to be out of the spine or the pelvis, and or visceral metastases. So any of those will categorize as a high volume. And this is the definition used by the AUA guideline. So that's something important to consider.
Perfect.
And there's now others emerging, like the SUO trial that we'll talk later, which are a little bit more frugal, I would say, in the definition, but it's better to keep the high risk and the high volume kind of definitions crystal clear as much as possible.
Thanks. And I'm just going to kind of interrupt our train of thought for 1 second, because we got a good question online. I'd encourage those who are attending to please, feel free to post questions. We love it. The question here was asking kind of about what you were discussing earlier in terms of the first generation anti-androgens like bicalutamide, and whether, are they truly not useful anymore, especially in that M1 setting? Maybe you can just answer that briefly, Ali.
Yeah, so I think as monotherapy, they should not be used. Then that's the main recommendation. I think in the M0 setting of a biochemical recurrence, they might have a transient role, but it's now hard to suggest that as a primary or a high level evidence, because now there are other drugs emerging in that space with survival benefits. So I would say they do have certain role in patients where you want to have some intermediate maneuvers before, let's say, being more aggressive on the treatment because other considerations outside of the disease. But I don't think as a monotherapy it should be used in M1 disease.
Thanks. So let's talk a little bit about management now. And it's, I think, mind-boggling to think about how management in this disease setting has changed over the last 5+ years. And at least I have to think about this really in chronological order. And so I start with docetaxel, which was kind of the first new agent to come on the scene. And so maybe Anna, could you walk us through the key studies as they relate to docetaxel and mHSPC?
Sure. So there were 3 trials that examined the effect of docetaxel in addition to ADT. And they were interestingly conducted anywhere between 2004 all the way to 2013. So the first one was GTEC-15. This was done in France. It was 385 patients, and they took 4 years to accrue, and this was published in 2013. The second one was Charted, and this was a 790 patient trial that accrued between 2006 and 2012 in the US and was published in 2015. And then there was Stampede Arm C, where they compared a number of arms, but including ADT plus docetaxel to ADT alone. And this was now 1,086 patients, and they accrued over the course of several years from 2005 to 2013 and published in 2016. They all allowed ECOG performance status of 2. They excluded active cardiac disease. They did allow prior ADT, say in the setting of radiation or what have you, and they had to have chemotherapy started within about 6 to 120 days of randomization. They had fairly similar populations in terms of age and ECOG performance status, but there was certainly a lower percentage of patients in the Stampede Arm C that met those criteria of high volume or high risk disease. And there were slightly higher numbers of or percentages of patients that had visceral disease in the Charted trial. Interestingly, the trial with the highest percentage of de novo metastatic disease was Charted, and Stampede Arm C had a slightly lower rate, so 73% in Charted and 59% in Stampede Arm C. Both Charted and Stampede Arm C, as you know, showed a benefit in terms of overall survival. Hazard ratios were 0.72 for Charted and 0.81 in Stampede. GTEC did not. A hazard ratio was 1.01. There's been a lot written about that. Did it have to do with the population? Were they underpowered? There have been subgroup analysis suggesting that, again, it had to do with the volume of disease. I think a really interesting fact about these 3 trials that sort of speaks to the heterogeneity of the populations and why we have to be very cautious in making comparisons between trials is the fact that the median overall survival of the control arm, so of the ADT arm, ranged from 44 months in charted to 71 months in Stampede arm C, whereas in the experimental arm went from 58 months to 81 months. So I think those are interesting facts.
Yeah, cross trial comparisons are no good. I think we can't say that enough. We should not do them. And we try, and we shouldn't. And people try, so we don't.
A lot.
A lot. Yes. And it's anyway, it's tempting, but don't do it. So that was awesome. And so we had docetaxel, and then along comes abiraterone with trials looking at abiraterone plus ADT against ADT alone. So Anna, maybe can you just keep going?
Sure. So here we have two large studies, approximately the same numbers. Latitude was about 1,200 patients, and Stampede arm G was 990 patients. It's always is interesting because the Latitude was conducted in 235 countries, which is I find an interesting fact, but more or less around the same time. So Latitude was conducted between 2013 to 2014, and Stampede arm G between 2011 and 2014. Of course, Stampede arm G was mostly in the UK, and Switzerland participated. Both of them were published in 2017. And again, as Ali mentioned, the Latitude included patients or mandated that patients had at least 2 of the high-risk features of Gleason greater than 8, more than 3 bone lesions, visceral metastasis, which was somewhat different from all the other studies. It was the Latitude also, I think the difference between Latitude and Stampede is the ECOG 0 patients were about half in Latitude, whereas Stampede, it was a better performance, or at least reported, of 78%. And again, in Stampede arm G, about half of the patients had high volume or high risk disease, as defined either by charted or by Latitude. So I think those are important differences to note. And again, now this time, both of the trials demonstrated an improvement in overall survival with hazard ratios of 0.66 and 0.61 respectively. There was a median overall survival was 36 months in the control arm of Latitude and 53 months in the experimental arm. Stampede didn't report the median, but at 3 years, 83% of men were alive in the experimental arm of abiraterone, and 76% of them were alive in the control arm. So these made abiraterone standard for hormone-sensitive prostate cancer.
Yeah. And then so we have that data, and then of course on the heels of that, we get additional data as you would expect, right? Everybody's waiting. Okay, what's going to be the next drug to come? As we have other agents in this setting. So, Kelvin, can you touch on what came next after abiraterone?
Sorry about that. I was muted. So yeah, the second generation anti-androgen, as Dr. Aparicio noted, these are competitive binders of the androgen receptor and also block cellular translocation as well as nuclear transcription. And so there's 2 agents that fall under this category. The first of which is apalutamide. This was studied in the Titan trial. Apalutamide is an inhibitor of the ligand binding domain of the androgen receptor. And Titan was a phase 3 trial, which was published in 2019 in New England Journal. And they randomly assigned 1,052 patients with metastatic castration-sensitive prostate cancer to receive either apalutamide or placebo with ADT. And what they showed was a 52% reduction in the risk of radiographic progression or death. And a lot of trials are using that sort of as a composite outcome. And overall survival at 2 years was 82.4% in the apalutamide arm versus 73.5% in the placebo group for a hazard ratio of 0.67. So essentially a 33% risk and reduction. The frequency of severe adverse events was actually quite similar at 42.2% and 40.8%. But as Dr. Aparicio noted before, one important side effect is a rash, and that actually occurs at a median of about 80 days after starting treatment. So this is something to counsel your patients on. The other drug in this class is enzalutamide. This was studied in 2 different trials. The first was Enzamet, which is a phase 3 trial primarily performed in Australia and New Zealand. They had 1,125 patients who received enzalutamide or bicalutamide with androgen deprivation, and the primary endpoint was overall survival. They too showed a 33% reduction in risk of death in the enzalutamide group, as well as significantly improved progression-free survival. There were more discontinuations in the enzalutamide arm, and importantly, fatigue, hypertension, and seizure are some important side effects to note. The other phase 3 trial of enzalutamide was the ARCHES trial, and this time enza was compared to placebo. This was published in JCO in 2019. They had 1,150 patients, and they showed a 61% reduction in the risk of radiographic progression or death, as well as significant improvements in PSA progression, skeletal events, and initiation of new anti-neoplastic therapy. As was expected, hypertension, fatigue, hot flash, falls, and seizure risk were higher. They're not comparatively different compared to what was seen in previous trials. And so on the basis of these trials, both apalutamide and enzalutamide have been approved in this space.
Awesome. Thank you. So I guess, there's one other treatment modality in this space that's in the guidelines that is maybe a bit controversial, and that's local treatment to the prostate. And so, Alec, can you walk us through the potential rationale, what the role is? It's, I guess the controversy I would say is that it's in the AUA guidelines. It maybe doesn't have as strong of a recommendation as some would say that it should have. And I'd love to get your perspective.
Okay, so you're giving me all the controversial questions. So
love it. I know you can handle it.
Yeah. So okay. So the rationale, I think I like to always put some context on the things, and then you'll get kind of my opinion towards the end. But radiotherapy, we did a track record showing that in locally advanced disease, for example, hormones alone versus hormone plus radiotherapy does render an improvement in survival. And those were the PR3 Canadian trial and the Scandinavian trial. And that kind of set the use of radiotherapy in locally advanced disease, where you could have presumed hormones alone would have been sufficient. And then in terms when the disease is metastatic of, let's start thinking like oligometastatic, and I'll get into that. There's obviously the primary tumor is a source of seeding. There's refined studies recently, not recently anymore, the time is frozen now, but a few years ago published in Nature showing the patterns of seeding, and also metastases can seed other metastases. So it's not only that the primary is the primary source of metastases, and also there are preclinical data showing the priming of the metastatic niche by the tumor secreting some regulatory substances, and that can actually favor the homing of metastases. So with that in mind, and also evidence from other malignancies, for example, kidney lesions, there were trials that were posed to actually test these questions. So one is a Dutch trial called the HORAT trial, published 1-2 years ago in the European Urology, and those were 430 participants that had high PSAs and bone predominant lesions because they were staged with bone scans. So that's one of the things to consider on that trial. And were randomized to external beam radiotherapy to the prostate only plus ADT versus ADT alone. Overall, not showing any benefit in survival. So that's an important thing. The trial was negative. But in a subgroup, which they defined those with less than 5 metastases, there was a kind of a signal that those patients may have improved survival, which was not significant, but they did have progression-free survival benefits. And then there's the Stampede H trial, similar randomization, ADT alone versus ADT plus radiotherapy to the prostate only. This is conventional image determine the M1, so CT plus minus MRI and bone scan. And again, the trial overall did not show benefit in overall survival in the entire population, but they did have a pre-specified subgroup analysis, which was not a stratification factor, but were well balanced between the arms of low and high volume disease. And those that had low volume disease as per charted. So just to recapitulate, that this would be less than 4 metastases, bone metastases, and abscess of visceral metastases. So those men did had a benefit in terms of overall survival and progression-free survival. So at 3 years, survival was 73% for those without radiotherapy, increased to 81 on those that received radiotherapy. And the toxicity was fairly low, about 5% of grade 3/4 toxicity. So that's a kind of the therapeutic index thought. So what do I think about all this? And if you close your eyes, I would say, like, the way I frame this in my mind is that in the y-axis, you have benefit of local therapies, and in the x-axis in the graph, you have effectiveness of systemic therapies, and that would be a curve like this. So the better the systemic therapies start to become, the local therapies have a plateau of benefit. But theoretically, if systemic therapies are extraordinary, at some point, the role of local therapies may decay over time, because now the systemic therapy can take care of the distant disease and the local high burden disease. And the bulk of disease moves this curve like this to the side. So if you have low burden of disease, even a so-so systemic therapy, the local therapy may be more relevant, because now you're tackling a small proportion or a significant proportion of the overall bulk of disease. So that's kind of my interpretation. I think as systemic therapies start to improve, local therapy may improve. And that's one of the key criticism, because now we don't know with abiraterone, for example, where does this benefit of the local therapy sits? Because now you can say, well, maybe now they're so good, the systemic therapies, that local therapies do not have such a benefit. So I think that's kind of the argument where it sits, and that needs a subgroup analysis again. So I think it has to be taken with a grain of salt and patient by patient.
Thank you. That's beautiful. I love the way of conceptualizing that. The slide here just shows a summary of the published trials and some of the ongoing trials that I think are going to be informative in this space. I see a question that somebody posted that I'm not seeing the curve that is being discussed. That the curve it's not. There's no slide of it. It's just a curve, I think, in our minds, but it makes a lot of sense, I think. So we're going to go to the next segment, and I'm going to make this a little bit of a lightning round, because if I'm sure we could hang out and talk about this all night, but the AUA will be mad at me. And so we're going to talk about kind of just really quick bullets on what are they, like the key issues that are coming at us, and they're major issues. And so first is germline testing. Kelvin, this is a big deal, especially in the metastatic setting. Why is it so important?
Yeah, it's been huge, and it's becoming much more commonly done in this space. And some studies that looked at familial syndromes of men with prostate cancer, then also association with families with a strong history of breast or ovarian cancer, really brought out the importance of BRCA1 and 2. And then if you look at the Pritchard study from last year in New England Journal, they found that 11.8% of 692 men with metastatic prostate cancer had germline mutations, most commonly BRCA, ATM-CHEK2, and PALB2. And it was actually not dependent on a family history of cancer or age at diagnosis. And this rate is significantly higher than those with localized prostate cancer or with no prostate or no cancer history at all. And it does have implications for types of treatment. We've heard about rucaparib and olaparib as far as targeted PARP inhibitor therapy, and obviously for family counseling.
Yeah, and maybe we can put up that slide that we have for this segment now, because that got the Pritchard data. on there. And it's a key study for those who haven't seen it, New England Journal of Medicine 2016, that shows that the prevalence of germline mutations in the setting and the potential impact, of course, that we now think about is in the castrate-resistant setting, the potential use of PARP inhibitors. But note that's not applicable at this point to the metastatic hormone-sensitive setting. Maybe eventually we'll have data that tells us otherwise. And what about somatic testing? So this is the germline data. What about do we sequence these tumors?
Very quickly, so somatic testing, as you all know, is indicated certainly in the management of advanced prostate cancer. And the big question is, when do you do the somatic testing? Although, so about 20% of metastatic prostate cancers carry alterations in genes that are critical for DNA repair and that predict for benefit from certain drugs, right? PARP inhibitors and possibly platinum agents. The issue is really the management changes for those alterations once the indication is there. And for the time being, the PARP inhibitors are indicated in the setting of castrate-resistant disease. So when possible, it's possibly a good idea to try to look for these alterations in the castrate-resistant setting. Having said that, a lot of the actionable mutations are present in the primary tumor, but there are a couple of issues with that. One is that the archival tumor can be old and have low yield. And of course, we may miss some alterations. So for example, AR amplifications and mutations can occur during the course of the disease and under the selective pressure of treatments. And so I think in time, we will see that it will become more important to sort of have a more contemporaneous look at the molecular profile of the tumor.
Yeah, that makes a lot of sense.
Does that answer the question?
I think so. Yeah, thank you. And so then the last thing I want to bring up in this section is, which we could spend literally another hour or two on, is the role of next-gen imaging, molecular imaging in this setting. It's a big deal. This is coming. It's going to be FDA approved in just about any setting, I think. Ali, what do you think? Where are we going?
I think is a caution is the word that I would say. It's going to be approved on primary staging of patients undergoing radical treatment, and also in the recurrent setting. So it's obviously going to cause yet another Will Rogers phenomenon in urology once again, in terms of stage migration. So I think what happens here in the M1 disease will be patients, let's say conventional imaging, their localized high-risk disease, and the PET shows a distant disease. Is that an M1, or is that a high risk that we used to treat in radiotherapy, for example, and the hormones would take care of that node in the retroperitoneal area? And I think there's no good answer for that yet. And in the recurrent setting will be exactly the same thing. So I think in the recurrent setting, the question now is a biochemical recurrence after treatment. We know is a pure surrogate of meaningful outcomes, while metastasis occurrence by conventional imaging is a good surrogate of overall survival. Where does recurrence unveiled by PET only falls within this subspectrum? Is it closer to a biochemical recurrence that might be not meaningful for the patient lifespan, or is it closer to the conventional imaging? And it's probably going to be not a yes or no type of answer. There's probably going to be indolent recurrences, which were some of the biochemical recurrence that now pick up on PET, and we'll have to learn which one of those actually are meaningful and which ones aren't. But I think it's important to know the evidence that we have today and the trials and the survival benefits hinge on conventional imaging. So doing the extrapolation may lead you to withhold treatments of benefit or give treatments with unproven benefits. So I think first do not harm should be the mentality as this field kind of evolves.
That's a great message. Yeah, first do no harm. That's very well said. I'll tell you, I mean, we have PSMA PET here. We use it frequently in the biochemical recurrence setting, and I would say that every single one of our tumor boards every week, we have at least one or two cases at something like this. And It's very controversial and we don't have enough data and we desperately need data. And of course, we just want to do the right thing by the patient, but we don't know what the right thing is truly. And we have to go with the data that we have, just like you said, first do no harm. So let's go. I'm going to take the liberty of going with it, keeping the discussion going till 8, and then we'll do the post-test questions after that, because I do want to go over at least 1 or 2 cases to illustrate a couple issues. And so let's talk about a 70-year-old gentleman with newly diagnosed high volume mHSPC. He's got multiple vertebral mets. He's got a liver met, no prior primary therapy. He's got good performance status. He complains of back pain. I want to kind of drill down the best I can on Anna's thoughts in terms of how you think about different treatments. How do you review it with patients? How do you conceptualize this in your mind? What do you do?
So, there's been a lot of discussion about the volume of disease and the implications as to the benefits of treatment. I think that's something to consider. But looking at the overall population, there's really, as we said earlier, we shouldn't really be doing cross-trial comparisons. There's only one sort of prospective contemporaneous comparison between docetaxel and abiraterone in this setting, and that was done by the Stampede group, right? So they had the control arm, which was ADT alone, and then they had the ADT plus docetaxel and the ADT plus abiraterone. And during a period of time of about a couple of years, they were randomizing at the same time to both of these arms. And so in that comparison, which again was contemporaneous, was randomized and not selected, there really was no evidence of any difference in overall or prostate cancer specific survival between docetaxel and abiraterone. So I think that in terms of efficacy, we have no data to support one agent over another. So then it goes to the question of volume, which I sort of addressed. Again, the Stampede group looked at the volume of disease and its impact on benefit from abiraterone or docetaxel in these 2 arms, and they did not find that distinction. As you all know, the chart was actually stratified for the high volume, but we've highlighted the differences in the population. So it would still be acceptable to treat a patient with low volume disease with docetaxel in my mind. So what I usually will sit down with patients and we'll go through all 4 options, and we talk about the impact of comorbidities. So if you have a severe cardiac history or hard to control hypertension, you probably don't want to go on enzalutamide or apalutamide. If you have diabetes that is difficult to control, you probably don't want to do abiraterone and prednisone. If you're on warfarin or some of the antiarrhythmics or some of the drugs that have interactions with enzalutamide or apalutamide, probably choose one of the others. If you have a poor performance status patient, maybe they'll do poorly with docetaxel. Maybe you would want to choose the other one. I think one thing that at least for me, has been more and more in my mind is this issue of financial toxicity. And so I think being aware of how much it's going to cost your patient to go on that trial is certainly important. But those are the considerations that I make when I'm trying to pick a treatment for a patient. Again, it's not based on perception of efficacy.
Super, thank you. There's a question that I also want to pose to Anna here, that is asking about androgen blockade, really with some of the new androgen targeting agents, and whether we can do it with intermittent, something we can consider in this with those drugs.
So there are 2 questions on the tab that I think are interesting. One is whether there's a role for bicalutamide in the first generation anti-androgens. And I would argue that the answer to that question is no, because for years we compared GnRH analogs to with or without bicalutamide, with or without flutamide, without, and at the end we put them all together, and there was maybe a 3% improvement in overall survival. And what does that really mean, right? So in this sense, so if you think that your patient needs combination therapy, bicalutamide is probably not your drug. Having said that, one thing that we haven't mentioned is that perhaps for certain patients, and LHRH agonist or antagonist alone could be considered. So I want to remind people of the SLOG 9346 trial, which was done back in the day when I was young, and before docetaxel was approved for metastatic castrate-resistant prostate cancer even. And for patients that achieved a PSA, an undetectable PSA of less than 0.2 after 6 or 7 months of treatment, the median overall survival was in excess of 5 years. We just discussed a little bit what median survivals we had seen in these trials. So I do think that there may be a role for LHRH agonists or antagonists alone in certain patients, particularly if they have high comorbidities. In terms of the intermittent therapy, I'm begging every company to please invest in doing trials that will tell us, because I am convinced that there are some patients that should benefit from intermittent hormone therapy, or maybe even possibly, androgen receptor inhibitors alone. I think that for a subset of prostate cancers, what we have to try to do is to do systemic therapy sparing treatment schedules, but we don't have the data, so can't comment really.
Awesome. Those, yeah, great answers. So I do want to be respectful of everybody's time, and we'll stop the kind of the main part of the discussion there, and then we'll just move to the post-discussion questions. And I first just really want to say thank you to the three of you guys. That was tremendous. We do have a slide. I guess we didn't put up. So this is really just reviewing kind of big picture treatment options in this setting, and then also the discussion around volume and risk based on charted and latitude. And again, I believe that these slides are all going to be downloadable. So thank you again, everybody.